Coming to you from Hardy, Arkansas, home of Spring River, this is Ridge Runner Reports, a podcast that will help clear the white noise in medicine and politics and help you define the forest from the trees. Direct from Ridge Runner Studios, here is your host, Big Dave Ezel.
Happy Easter weekend, everybody. I hope y'all are all doing okay today. We had quite an exciting day on Good Friday here in Hardy, Arkansas. We had a tornado touchdown in Cherokee Village. There was no loss of life. There's a lot of limbs and stuff down. A lot of roof shingle damage, that kind of thing. Nothing major, no loss of life, so we're thankful for that. I hope everybody else out there is having a good Easter weekend so far. I trust everybody will have a wonderful Easter day tomorrow. Today we're going to talk about something that's kind of just come to light to me. I know it's always been there. We've heard about it, but it's getting real interesting. And I've wondered why we can't ever get stuff like this in nursing, why we don't think about it in the beginning time when we're applying for a job, for what we would get in our pay packages and an employment package. What can we actually do to benefit us other than the hourly rate? There's never any mention of these when you're doing an interview, which is funny to me. I mean, what would be wrong with saying, okay, here's the deal. We're going to give you this much an hour, and we're going to have you scheduled. If you prefer blocks, we'll do your blocks, but what we need to know is you need 2 days off a week. We're going to give you those 2 days off every week without question for a mental health break. So you can take some you time and do what you need to do to get your appointments done during the week. Give you time to spend with your family, give you time for you. I've never heard that ever, and I've been doing this a long, long time. Most jobs don't do that, so you don't really get your decompression time. You don't get to process the things you've seen during your shifts and stuff. Basically, these facilities do not care about either one of anybody that works there. They're only really worried about the bottom line. And if they don't have to make an expenditure, they don't have to. They will not do it. There's a stigma, though, in healthcare we don't talk about at all. We got a job, we get paid. They just want us to shut up and go on about our business. Because even if we do see the mental health, if there's stuff that you can't handle for, there's outside forces. They'll come up, and what everybody's worried about, you can't confide in anybody with it. And I wouldn't with mental health, but confide in anybody except the person that I'm married to or dating or whatever, that I live with, that I know it's going to stay where it is. Pillow talk, I guess. And if they get mad at you, they're going to call the board. Oh, you were dangerous. They take medication for their mental health. And that's why we don't do it and we don't talk. And I don't understand why. They will take that, and then they'll call, the nurses will tattle on the nurses when they get mad at them, especially because I've mentioned the Karen nurses a bunch, and that's exactly what it is. These goody two-shoe nurses that think their punta don't stink, and it actually is the one that smells the highest. We've got to figure out how to do it and keep this stigma down. What is becoming known to fact in public, and a lot of people don't know because they don't care about it and they don't pay attention to it. If they hear it, it's just kind of a fleeting thing because, oh, we hear that from a lot of people right now and that's what's going on. But But the stigma of not going to get help is probably the driving force with the increase in suicide in the healthcare field and nursing specifically. And nurses fear they go to seek for mental health. It would harm their professional standing outside in the public and within the community of nursing itself. It's actually there. People don't believe it is. It's there. It's strong. And it's a well-established premise that we don't seek mental health care, in nursing specifically. But we need to at least acknowledge it and overcome the stigma associated with it within the culture of medicine itself, and noting that the silence and the inaction that we don't do about it now will cause problems in the future and might prevent one, if just one, nurse from committing suicide or attempting to take their lives and go in between it. I'm going to tell you a story about a nurse that I met on one of the nursing pages that I'm in on Facebook, and we had a long conversation one day regarding it. And she basically was in her car one day driving, and it just came in on her like a ton of bricks, she said. But we'll get to that. We're going to give the commercial for my show sponsor at Rocking Magnolia Customs. So we'll get a few words from them.
Do you have a friend or family member you're having trouble buying a gift for? You just can't find the right gift for the person who has everything? Then go to Rockin' Magnolia Customs, a place where you can pick out and design the perfect gift for that special someone. That's RockinMagnoliaCustoms.com, or find them on Facebook at Rockin' Magnolia Customs.
And that's Rocking Magnolia Customs, and Customs is with a K, and you can find them online at RockingMagnoliaCustoms.com. I was talking to this nurse, and she was talking about she had two that she worked with in her unit, on her unit, in her nurse's station, and they pretty much had the same schedule. She lost one of her nursing buddies to COVID-19, and she lost the other buddy that she worked with. She was particularly close to suicide. The problem is the burden of work and life during the pandemic, especially for nurses, but specifically for the female nurses, was disproportionate. The toll that fell on the women in nursing and healthcare during COVID-19 was disproportionate to the rest of society. Female nurses had to have double the risk of suicide in women in the general population versus women in the healthcare field. We focus so much on physician welfare in the past. Oh, these residents, they're working too many consecutive hours. We need to stop that. It's not healthy. We need to do that. And the whole time we've done it with the physician side and advanced practice people in medicine on their side, making sure they have enough rest and that they're going to get their time off. But we did not focus on the whole healthcare field, specifically nursing and specifically females in nursing. She was telling me basically this past fall, she was driving to a dental appointment, and she just said she was making a turn and going to the clinic to the dental clinic, and it just fell in on her like a ton of bricks. She had anxiety setting in her car. She just wanted it to go away. She wanted it to all stop. Everything that was going on, she was flashing through her head that had gone on the last 2 years, or year and a half at that time. And it was just all flooding back in. She just wanted all of it to stop. She wanted the racing thoughts to stop. She wanted the memories of the years, memories of her friend, and then she committed suicide, and what all they went through, and all the people that she worked with, her colleagues on other units. And it was bad. She said it wasn't really that she wanted to kill herself per se, but she just could not quit thinking about it. All she wanted it to do was stop. And that did cross her mind. She didn't have a plan, but that did cross her mind. So she went and she got her some help, and it's, said one thing that she found out during all of this is that the risk factors for suicide among healthcare workers was two things. Work-related stressors, the stuff that we see at work, deal with at work. And if there's any underlying mental health problems that's not been specifically seen, identified, or diagnosed prior to this stuff happening. There's specific areas of the hospital and healthcare that are affected, but specifically for PTSD. Yes, you don't have to be on the battlefield anywhere to obtain PTSD. Nurses, we deal with death every day. We watch people die on a daily basis. Nurses that are in the specialty units, MICUs and critical care ICUs and cardiovascular ICUs and ERs. ER nurses specifically witness massive trauma in all different age groups. They witness death 2 or 3 times a shift. Same thing if you compare it to nurses to the last front line of the battle against COVID. Well, guess what? That means that we're fighting a battle nobody wanted to, just like the military does. And yet nobody wants to take care of the military. Nobody wants to take care of the nurses, all committing suicide now. I'm a massive avid supporter of the Till Valhalla Project. They work trying to raise money for family members of victims of suicide in the military after they get home. And because they recognize and know that there's an issue that approximately 22 veterans a day are committing suicide. When I went to doing this statistic kind of caught me. I already were aware of the veteran suicide, but with the nursing suicide rates in some areas of the country, they're greater than 22 a day. In some areas, they're less than 22 a day. But the average, the fact that nursing in America during COVID is causing nurses to commit suicide at the same rate, because PTSD is real. It's a true traumatic brain injury. The more we study about PTSD, the more we realize it is actually a massive disorder. It's just as good as being shell-shocked, because that's basically what it is. Dealing with a higher burden of death and trauma puts all of these healthcare workers at a higher risk for developing symptoms of suicide. They have previous history of mental health. Maybe they had something in their childhood before they became a nurse, or adulthood before they became a nurse, that they've already got PTSD. And by the job that we do, it's brought that back, and they never dealt with that the first time. So now they're having to deal with that, plus being in the healthcare field and working 12 hours and going home and running your errands and getting 6 to 8 hours of sleep a day if they're lucky. Being tired plays into it, not having the time to actually stop and deal with the issue. In PTSD is something we don't do a lot of studying about. You hear a lot about it. You see a few reports. It's 3 or 4 minutes long on the news, but we don't do anything about it. Emergency room physicians, because that's what we paid attention to. Probably 30 to 40% of the physicians that work emergency care in any form of it are all suffering of PTSD. That what happens, nurses and doctors have people's lives in their hands every day for a majority of the day, every day. When you start structuring all of that, maybe you got something bad going on at home and then your work plays in. I mean, there's so many outside influences on us every day. And then you add something that wasn't there previously, say COVID, massive flu outbreaks. And we've been through them before, but we never dealt with the post side of it, and specifically the mental health side of the healthcare field. When I was doing a lot of this research, I found several articles on it. I was kind of shocked there was that much information about it out there, and I never heard half of this stuff. You've got, we do factor models when they're doing research. You got what are 4 factors, or what are 8 factors, or what is that? Well, there was a 7-factor model that they used that's taken all the stuff into account. That really caught my attention. Especially in healthcare, and we were talking about the different departments that I was talking about a while ago, and then the different people that work in those different departments. Critically ill patients, that would be after all the emergency stuff is left on, and you've got that down in the ER where they dealt with what's called direct PTSD, because they saw the trauma post and it really affected them. And then we sent them up to, say, critical care units, but those people that work there will develop depression because they get to deal with the aftermath along with the family that gets to deal with the same aftermath. I never thought about it that way, but that's so true. Having worked in CCUs and ERs earlier in my career, I had it and didn't even realize it. And to show you that nurses dealing with death, I've been doing this a long, long time, 25 plus years. I remember my very first patient that that passed in front of my face. I can see her face. I see her daughter. I can see the bed she was laying in. I can see exactly how the bed was raised up to help her breathe. She was an oversized lady. She had COPD. She'd had a heart attack, and they just couldn't get her heart to work. She had an external pump pumping her heart to keep the fluid from backing up. And all of that just weighed in on me. And when she passed away, I was not working that day, but I got a phone call that she had passed away. I was devastated. I didn't realize that all of that gave me PTSD. And I didn't even really understand it. And my wife passed away and I was doing grief counseling. And after about the 4th session of the grief counseling, she looks at me right in the face and she says, okay, I think you've got this grief. We've got that going on really good. Now we're going to deal with this other problem you've got. Other problem I've got? What could be worse than dealing with the loss of my spouse or my wife? What could be worse than that? She said, well, you've got PTSD from the job you do. And I really just had to sit there and look at her. I said, because I thought, well, I didn't go to war. I wasn't there. She said, it's misconceptions, David, misconceptions in healthcare. And I never thought about it. But as we got into it with the therapist, and I'll talk about it because, they can report me to the board of nursing for going to get mental health. And if they do anything about it, I will blast them all over social media and put their names out there and say they don't want you to have your mental health care. It's ridiculous. And then you've got all these systemical effects of this going on in the healthcare industry. You hear stories all the time of nurses stealing narcotics and abusing them. We talk about that all the time. All we ever really hear is, she's hooked. She steals that medicine. She's hooked. And never ask the question, well, I wonder why she's stealing it. Is she stealing it for her? Stealing it for her spouse? Is he stealing it for this? Is he stealing it for that to sell? There's all this stuff. And when you've got these, especially benzos, and that would be your Xanax and Valiums and stuff like that, and opioids, which would be your Norco and hydrocodone and oxycodone and morphine and things like that. When you're dealing with stuff like that, we never ask what caused them to get hooked. There's always a psychological undertone for abuse of people, abuse of, in a normal sense, abuse of drugs, abuse of alcohol. Nurses are, a lot of nurses are alcoholics. They don't want to admit it. I will tell y'all that I drink after work sometimes because it's a bad, stressful day. Well, you have a bad, stressful day every day. I don't drink. I never drink every day. But there are a lot of nurses that do, and if they're predisposed to alcoholism, well, here we go. We've got that to deal with now too. So when you take all of this information and you start really thinking about it, and then you think about, oh, well, these congressmen don't want us to do anything about it because, they might have to do more money, and we really can't touch if it's designed to go straight to mental health, because that would really be a political issue I don't want to deal with at all. Nurses won't do it because there's fear and uncertainty about their job, because we got these caring nurses out there. Oh, if they get mad, I'm going to call and turn them in about that, because it's wrong for them to be out there treating somebody when they're a patient themselves. Well, Karen, you need to go get you some review to find out why you're such a female dog. And the Richard nurses too. Don't think Karens are inept. There are Richard nurses too, male nurses. You know, Richard, y'all know what Richard's nickname is, right? That would be part of the problem too. Previous research in all of this, when I started reading it, has shown me that healthcare workers' mental health consequences during an epidemic or a pandemic is long-term damage in their health care, especially their mental health care. And imagine the nurses that work these units where they get abused by the patients. They're dealing with that too. I just never thought about it. I guess that's why I'm so flabbergasted with it. Due to the nature of the jobs that we do during the pandemic, because we did a lot of different jobs, emergency department staff, nurses, intensivists, physicians, they are the most vulnerable group to experience any stressful event that might trigger a suicidal crisis. And people have suicidal ideations all the time. Just in passing say stuff, I would be better off if I was just dead. Everybody would be better off if I was just dead. That just, no plan, no way to act on it. Really a Benton mechanism statement, in my opinion. But when they are having these problems, you know they're having these problems, they look tired, they act tired. It may simply be a metabolic issue. They may not be getting enough nutrients in their food. They may need a multivitamin or vitamin A or D or one of the big five, A, D, E, K, C, zinc, and potassium are major mental health chemicals in the brain that help with your mental health. So, I mean, there's all different things, but if you don't ever go get seen about it, how are you going to know? It may simply be you might need some vitamin D, ladies. Most ladies do. They don't drink enough milk or eat enough milk-based products to get the vitamin C and D that they need. Stress, anxiety, depression, insomnia, all this stuff's increasing amongst the healthcare workers. I see it every day. I worked with a nurse this past week that I hadn't worked with in a while, but I noticed she had the shakes in her hands, like nervous. So that's anxiety on just a visual level. And this research is going on all over the world. It's not just the United States nurses; it's all the nurses. But the one that's the most, the Northeast specifically, have an increase in nurses' death that they knew were nurses. There's an increase in nurse and deaths. Among those, suicide, but also accidental overdoses. If these healthcare facilities really cared about suicide and nurses, they would have a supporting workplace that cared about it. They would make it mandatory every year on your evaluation. You have to have a healthcare screening. Other fields of work do. Police, large police in cities, they have to have a mental health evaluation every year. And my thing is, if we don't, let's just put them off the front lines of nursing. Oh, we can't do that right now. We are so short. You know what? You're going to be shorter if she's gone and you can't get her to come into work. She's not here to work anymore. Then you've got a worse problem than if she misses a day. In this recent study in JAMA, they found that the suicide rates among the nurses was much, much higher than the general population, but physicians and the healthcare field didn't change. They still had the same amount of suicide. So nurses will go get help if they know they need it, because they put their family before themselves. They put their husband and spouses above themselves. And we have to come up with approaches in healthcare to stop this. It's BS. Not dealing with the problem you've got. Because we teach patients all the time, well, you've got this problem now, you've got to deal with it. But we don't give ourselves the same advice of saying, you've got the depression, you need to go get dealt with. You need to go deal with your issues, and you need to take some time for yourself. And when you hear that, the facility has waited so long because they don't want to pay extra to per diem nurse or travel nurses. Men will go to the doctor more easily after their PTSD, depression, anxiety, stressors all start messing with their nature. If the pecker don't work, they don't feel like a man anyway. There's a lot of psychological stuff with that, but when it starts affecting their sex lives, men will go to the doctor and figure out what's going on. I just for instance, I had a female nurse friend that I worked with for years, and she told me one day she came in, she looked tired, she'd been off on vacation for a week, and I said, what's wrong? She told me her husband would never leave her alone. He was also in the healthcare field. And I said, well, he won't leave you alone. I said, well, there's worse problems to have than that. She said, no, you don't get it. We were just average before, and then he went and got him some help and got him some Zoloft, and now he just will not leave me alone. I said, well, just act like you're 20 years old again, being newlyweds. There's nothing wrong with that. She said, yeah, I'm not a newlywed, and I'm not 20 no more, David, so there's the problem. And I laughed about it, and I got to thinking about that when I was doing this research. Men will go before women will, because there's not as much stigma against men for going to get help than it is women. We've got this uncommon view of women that they're these strong mental health people and they can deal with stuff. They raise these children and deal with their husbands and deal with their spouses, whatever your case may be. We put that on women undue. They don't deserve that. Everybody should have the same amount for the same thing. We've got to come up with approaches in healthcare to get the nurses and the healthcare workers the help they actually need. A tailored approach is we got to break the stigma of seeking treatment on these. What I talked about was gender stereotypes before, just prior to this statement. We've got to stop that. Why will men go before women will? Let's see what that is, and then if we can fix that part where the women are going the same as men are, or we can increase the help they're going to get. you deal with that. Telling your nurses right off the bat, if you go get mental health and you need it, you need your mental help, we're not going to report your license. We're not going to report it to them. Now, I believe if you've got a severe case and you're having some problems, to the nurses, now I would probably call, especially if they say you need some inpatient treatment for your depression. I would definitely call the board of nursing and notify them what's going on, because then if something happens, with these DAs wanting to prosecute nurses left and right now for murder with no intent and winning those cases like that, that would be something you probably need to report. Because there's still going to be Karens and Richards. If we could learn how to deal with Karens and Richards in the healthcare field, then we would have most of that taken care of. And then let's have the leadership in these healthcare facilities encourage their staff to take 2, let's say, mental health days a month, back to back in a row, and then have the scheduler schedule a day before or a day after those mental health days. Let's make that part of the pay package, nurses. If you're wanting to get higher pay, get your higher pay and say, I get 2 days off back to back in a month. They're going to be scheduled in before my schedule is made. Let's get you some mental health days. Let's make sure that every year they take a minimum of 5 days off in a row and call it a vacation. There's a model idea. Or maybe they can take a weekend and add a day before and a day after the weekend and take them a 4 or 5 day weekend and spend time with their family, or go to Vegas, or go traveling, or anything to do other than deal with what we deal with every day, which is healthcare. You have to change these workloads that you're putting on these nurses. It's getting ridiculous, folks. I've been in it. I've worked acute care and I've worked long-term care, and I love LTAC work. But if you've got 4 critical patients, it's impossible to do everything. You're holding 4 lives in your hands for the next 12 hours, and they want you to do that without making a mistake. Those are not achievable goals. Those goals are hard to reach. You're not going to be perfect. You are a human being, and you're not going to do it perfectly. We've got all of that going on, just regular work before the pandemic. Now you've added these undue rules. Oh, you can't work in this medical building without putting this mask on. But yet you can go to Walmart and be around 100 people before you go to work. But you got to put that mask on when you get to work because CMS said you're going to do it. The government don't know what they do anyway. Why are we relying on the government? We all know they don't know what they're doing. They took a time picture frame from 2007 to 2018, just suicide cases from the up-to-date suicide information they had in the database. And there was 159,000 suicides in that from 2007 to 2018. Of those, 2,400 of those suicides were nurses. This is prior to the pandemic dates, okay, people? Just keep in mind. 8 to 10 of those 2,400 were women. That means that in this study time frame, all the healthcare suicides in nursing, 80 to 85% of them were women. And in the doctor side, the medical doc side, 850 suicides of those 2,400, and 85 to 86% of those doctors were men. Keep in mind, it's 159,000 suicides. There was 315,000 all totaled different suicides, accidental overdose. It was classified as suicide, all of that in the country. And most of those were men. Together. But the suicide incident with nurses post-COVID is 19.1 per 100,000. The public is 8.6 per 100,000. That is doubled. Well, that's over doubled for nurses. And the stuff that I've just previously mentioned about what facilities can do to stop it, and they're not doing anything to stop it, they don't care. All they care about is the bottom line. All they care about is the color you can put in their pocket, which is green. Nurses basically will poison themselves most of the time. They'll take a ton of pills or anything like that. Men won't. Men don't care. Women worry about everybody having to clean up after they're gone. Men don't care about that. And then you wrap the access nurses have to medications and narcotics, and they might be abusive, drinking, and then you add a pandemic on top of it, drug use on top of it. No wonder the rates are skyrocketing through the roof. Now, I'm not saying out there every nurse out there has got PTSD and they are all taking pills or they're all drinking. That's not what I'm saying. I'm saying there's an incidence among the nursing population is just like the incidence among the general population. Anything to lift that burden off of our shoulders, we'll do it. Depression, stressful events, and prior mental health issues for any nurse are the main reasons. And then you got these facilities that makes our jobs more challenging by putting more responsibility on the nurses. Oh, well, they're just the nurses. We're going to get rid of the housekeepers and they're going to have to clean the unit themselves. They're going to clean their workstations themselves. Well, I agree with cleaning your workstation. It's not what I'm saying. But I mean, we sit there and have to empty the trash and mop the floor and wipe off the counters in there and clean other shifts left. It starts to weigh you down. So we've got to take away the stigma of getting help, the stigma of maybe losing your license if you go get help because Karen or Richard didn't like you, or you shunned their advance, or you just didn't seem to have problems at work. You got along with everybody. And then you got all this regular stuff going on. Then you throw the pandemic on there. And I'll give y'all an example. When the pandemic started, I was working in Kansas City, and I'd work a week on and a week off. Well, we weren't having no visitors and no family members being able to come into the facilities. These people that I worked at knew my schedule. One day when I walked into the front door and I checked in and got my temperature taken and filled out the questionnaire and all of that stuff, I had 15 or 20 residents waiting on me to get there because I was the closest thing to a family member that they had seen that would come in and visit. And the brevity of me working a week on and a week off finally hit me. These people hated to see me leave, but they loved to see me come back because nobody had been to see them the whole time. So I made it a big game. I would tell them when I would be back. They would all be waiting on me. When I came in the door, it was like coming to Grandma's house. I would just start talking to all of them, hugging their necks, all the stuff they told us not to do. I broke the 6-foot barrier rule. I treated them like they were my family because I realized they were. They really, really were. It's just sad. And I want to see the breakdown between male nurses and female nurses and male doctors and female doctors, where that's just the study they focus on. Each studies had different sections of the healthcare field that they did, and they combined all of their numbers into one study, and it's pretty accurate. But here's what I found that I'm going to talk about. Where we are post-pandemic. Now, prior to the pandemic, I told you it was 17.1 per 100,000. And 20.1% per 100,000 for men and 17.1% for women prior to the pandemic. Now, let's flip that around. We're post-pandemic. And the male nurses were up to 20.1 per 100,000, and the female nurses were up to 23.8 per 100,000. What's the big increase that happened? It's when they set back for just the men. They were still lower than the general population's rate of suicide. But the numbers between nurses and doctors in the male side of the healthcare industry are now dead even. 30.1 for nurses and 31.5 for physicians. Why? Nobody's done that part. They don't care. You got doctors that make these massive decisions between life and death. Men in nursing, we want to go help our counterparts, which a lot of the time are women. We'll go help our counterparts. So nurses call the doctors to get help managing, and then nurses will turn to the male nurses on the unit, and the male nurses will go over to the female nurses to try to help them the best they can, because we help each other out. And I'm thinking maybe that may be why the male nurses and the male doctors' rates are dead even. Death in the long-term care is a little bit easier than it is in the hospital. Long-term care, we deal with older people, and they've lived their life, and their expectation of stuff is not as great. I mean, any death is not right. It's normal, and it's a beautiful part of the living process if it's handled correctly. But it's still death. But when you don't, they've lived their life and you're expecting it, or they're in long-term care on hospice and they're passing away, you expect it. The ones you don't expect, which is what the ER deals with, is sudden death, or sudden cardiac death, sudden traumatic death, anything like that. It leaves an imprint in your brain that you probably have a hard time getting over, but we won't go get help because we're scared to go get help. We're scared of the consequences of going to get help. American nurses are experiencing suicidal ideation in greater numbers since the pandemic. And the nurses who experience the suicidal ideations were less likely to seek professional help. And then we're going to talk about burnout, but burnout is a major risk for nurses that would trigger suicidal ideation. I use burnout there because it's not really exploitation. It's the fact that we are tired. We have worked, these facilities exploited us and caused us to have burnout. Imagine all of these stressors going on, and then you're so burnt out on your job that becomes the period on the exclamation point for people. Nurses are experiencing higher amounts of PTSD, anxiety, sleep disorders, depression. It's affecting their well-being, but healthcare facilities aren't doing anything about it because they can't afford for a nurse to be out sick, and that's the government's fault. We have this shortage of nurses right now. It's everybody knows it. We have that. You've got that increased amount of stress with the higher care population each nurse has. That's the patient ratio, is care population. And then when we normally used to work 3 12-hour shifts a week, now we're 4 and 5, working anywhere from 36 to 72 hours a week. I've worked 5 12s in a row. You get tired. And then if you don't take your 2 mental health days, or your 2 days off in between or more, that's why I worked 7 on, 7 off. A lot of times it was 6 on and 8 off. But I got the time and broke in between. That's probably what saved me from having so much stress. And for the PTSD, I got to kind of cope and go through it. Facilities have to, without fail, they have to improve the work environment for all their healthcare professionals. If they don't, we're looking at a loss via suicide in staffing people available to work. Now, the quitting, changing jobs, all of that, I get the stress that causes them to do that. But facilities really have to create the time to sit down and figure out how to pull all of this extra crap off of the nurses, where the nurses can just take care of their patients or their residents. We need to take these rules and regulations that CMS requires. We got to change them and optimize them. You can't just knock them out. You have to find another way to implement it. Because the upper management in these healthcare facilities don't care how you get it done. Just get it done so we can get our money. Facilities need to start having enough resources. That means staffing. A lot of undue stress on nurses is because we don't have the supplies we need to do our job. And they can say that it's a supply chain issue. The problem was we didn't have the resources prior to the supply chain issue. That's not an excuse you can use anymore. If you don't start doing things to create a manageable workload, a safe workload, a safe ratio for the protection of the consumer that's buying the health care, you're not going to have people going to the doctor. You got nurses quitting. You're going to have an inept, ineffective health care delivery system. Facilities need to make sure they reduce the stigma for nurses going to get mental health. If you're a hospital and you've got a psychiatrist on staff, please just hail the psychiatrist on staff. You're going to have to start seeing our nurses as patients. We'll put you on contract for that, and we'll pay you $50 a nurse. Why? Because they're required. And you need to really know that once we say that our nurses need mental health, you're required to do it. annual mental health screenings by the facilities on their nursing staff. If they get a report that a nurse is having problems, she's been crying every night she comes to work, or she came to work with a bruise, and we want to make sure everything's okay with her, then the facility says, okay, you got to go do your mental health screen with a psychiatrist before you can come back to work. And do it with all, so the nurses don't quit the job that's actually going to require them to go get help for their mental health stability. And then if they need a longer time frame to get better, then the facility should make sure that the mental health for the medical staff they have is accessible, affordable, and super, super confidential. Now, I go to mine, excuse me. I didn't have no trouble. I told everybody I went to, I love it. I loved it because she'd give me some mechanisms to deal with my stress, not just from the loss of my spouse, but also from my job. Because I'm still going to see my psychiatrist. I do it on Zoom a lot because we're not dealing with my grief part anymore. I'm actually dealing with the stuff that I had 25, 26 years ago. I'm dealing with incidents in a prison that I worked that I had no idea was even affecting me until I started doing the counseling for it. And that's the thing that's opened my mind up. And then I keep on seeing stuff come up every day. But suicide in the nursing field right now should be priority number one for any healthcare delivery system in the country. Comparative like this, no script. This is free speech here. This is, I have my little outline to keep me on focus and try to keep chasing rabbits around and around and around. But here I'm going to, without trying to chase rabbits, speak freely. Nurses are in the middle of a march. We're in the middle of trying to raise awareness that what we want is what we're owed, and we want the safety of the patients we take care of increased tenfold. With this march, with these marches, with these awareness stuff going on, we need to also be saying, and we want mental health system designed for nurses, for healthcare workers in particular, to be able to deal with the stress. And we don't want nobody getting in our way to get it, and we don't need anybody threatening to take our license because we do go get it. Because if we go get it, it makes it inconvenient for you, then it's you. And I'm not saying all facilities are that way, but a lot of facilities that way, because if you're not there, it messes with their pocket. Their bottom line. And I hate to even say it that way, but we all know it's true. So now that they have effectively begun the process to destroy healthcare, they've destroyed every other part of the American existence in D.C. Nurses are standing up thinking their voices matter, and they matter, but they don't matter in D.C. You see. Because at the end of the day, all these owners of these hospital systems, the majority of them are privately owned. Those privately owned people are in one city somewhere in a gated community, locked up behind that locked gate, and they don't have to deal with you in another city, in another state, in a small town or a big town. And they just won't do it unless they're forced to do it. So I hope the people that's in the march, I hope that either Jessica or one of the ladies from the nurses march hears this and realizes this is just as important part of the patient's safety, because it is for the patient's safety, for their nurses to be physically ready to work and mentally to be able to work. I had a friend in the last month. She was a nurse that I worked with years ago. I had talked to her a few months ago, and she was having some trouble. And I talked with her. And when I was on the phone with her, and we were on FaceTime or Messenger talking, we was talking to each other face to face. And I was on my laptop doing research, and when I was talking to her, I just started looking everything up, and I was giving her. She was writing it down, and she was doing everything. Then about a week and a half ago, I got word that she had committed suicide. That she didn't make it. She was a damn good nurse. She was an even more extraordinary human being. But the stress of dealing with a deadbeat husband, having to take care of her kids. She had to take care of her mother who lived next door to her. She was terrified during the pandemic that she was going to take home COVID and kill her mother. When you start adding all these stressors on like that, what do you think's going to happen to nurses who are predisposed to a mental health crisis? Because all nurses really are. If everything that keeps going with this pandemic shows that it was, and I'm not saying that it is, but in conspiracy theorists, there is conspiracy theories out there that say it was planned. If that ends up being the case, then the government should be held responsible for the murder of the nurses that died on their suicide because they created an undue circumstance that caused them to break. I've mentioned before, and I'm going to say this now, anybody that messes in with the healthcare delivery system and interference causes death, and if these DAs are going to prosecute nurses for med errors as murderers, and they're going to say you murdered the patient, but you didn't, you don't need intent to murder somebody. Well, you're changing the rule for everybody. But until we sit back and say, hey, a DA, you're interfering with the chance this nurse can get mental health if you're waiting just to prosecute them. I really believe there's a war in healthcare right now. I think the government's initiated the war in healthcare right now. If not, we wouldn't be having all these change rules, cutting budgets, causing angst amongst the public and the healthcare workers, and the healthcare workers with each other, and the healthcare workers against government, in a bid to try to take over the 20% of the gross domestic product that is the healthcare industry. Then they should be held accountable too. DAs. So the rules put forth by the government, if they indirectly cause a patient to die, then the government official should be held responsible for it. And I'm talking about the Secretary of HHS, and I'm talking about the Undersecretary of CMS, because they're ultimately responsible for the health care of the country. That's what happens when you pass the socialized medicine in 1964 and the American Care Act, which is anything but a care act, in 2013. I'm going to do a lot more research on this. There was probably 30 or 40 articles that broke down the depression and broke down like schizoaffective disorder and narcissism amongst nurses. I mean, it was article after article after article, and the specifics is what I really am wanting to get into in the next little bit. I'm going to end this show on the mental health of nurses. Now, preview of what's coming up. I've started checking into these cuts, the $323 billion that they cut from the CMS's budget. I'm checking to see why. I've got an idea why they cut it, but I'm going to make sure it correlates. And I'll premise that with this. The very first statistic that ever came out from COVID that really stuck in my head was not the amount of people infected and the amount died. Though you're going to have a death count. You have death counts and natural disasters too. I mean, they had a death ticker when that apartment collapsed in Florida last year. In the bottom right-hand corner, they had it injured and death tickers in the corner. You're going to have that with this stuff. But if it proves that they're going to cut the budget and stuff, it's going to affect the direct care a patient receives, then the hospitals or the government officials need to be held responsible. For instance, the governor of New York was Mario Cuomo. He's made the nursing homes take the COVID positive patients back into their facilities. There was an alternative place to send them in the docks. Was the health ship was there. I think it was Mercy that was in New York. If not, you can send me an email and correct me, or send me a message and correct me in my messenger on my Facebook page, Ridge Runner Studios. But since he forced those nursing homes to take those residents back, and it flipped around and it triggered 16,000 deaths related to his mandate that his nursing home take his residents back in their buildings in New York, because we all know that CMS pays those healthcare patients' bills 100% for 21 days. Governor Cuomo did it for nothing more than his state to get the CMS funds, which was probably, with that many people in New York, probably in the billions of dollars into the state budget, state coffers. Then I want the Attorney General for the state of New York, the one that didn't get arrested last week, to understand you have a responsibility to the public for the governor to A, be charged with elder abuse, because he put those sick people in there knowing they were going to infect others and knowing they were going to die. And B, because he stuck the infected in there knowing they were going to get sick and they did die, his should be murder too. 16,000 counts of murder. Because he's not any more out of the woods for elder abuse than anybody else in this country that can be charged with elder abuse. It's never going to happen. I have no faith in the government anymore because of the stuff that's going on now and has gone on in the past. But it's just some thoughts to ponder this week. We made it to the end. Again, I'd like to thank Rockin' Magnolia Customs for getting my cup to me this week. I really, really, really love it. I've been drinking out of it since I got it yesterday on Friday. Sorry it's taken me so long to get my podcast out today. Apparently, something happened in my computer. I've got a bunch of corrupted files. I've either got a virus in my laptop or the weather caused the files to corrupt by a surge in electricity or something, because our lights went on, off and on all night last night. But I've got it re-recorded. I've got it done. Sorry if it's not as consistent as I'm trying to get. If you got any questions, you can access me at Ridge Runner Studios at protonmail.com. If you go to my Spotify page and open up my information, all of my info is there. You can send me a text message or send me an email. But until next week, this has been David with Ridge Runner Studios and Ridge Runner Reports. Y'all have a great weekend. We'll see you next week.